will say that this is what I'm presenting. It's joint work with a number of people, particularly Zlan Fang and Troy Day, with whom I've worked for, well, a very long time, Zlan, and a couple of years now with Troy. But there are others, and I finished these slides early this morning, and so that they have, so I'm reluctant to put their names on them. Let me tell you a bit about what I plan, and then I'll turn my camera off for the presentation. I'm going to describe, none of this work is published. I'm going to talk about how our current model differs from the one that we published last year, and then I'll compare its predictions to accurate independent observations, and finally use it to assess the respective impacts of our vaccination program and two hypothetical alternatives. One of these is increased coverage. I think you used the word uptake in Europe among those aged 5 to 15 years. And the other is allocation of the doses administered week by week in the locations that we model to eligible residents in proportion to their age-specific contributions to the metapopulation effective reproduction number. And these, both of these exercises are motivated by some.
Dr. Glasser, can we ask you to cut your camera off, because I think it might make the connection a little bit smoother.
The next generation matrix. So let me see if I can turn off my video and switch to. I'm talking from rural North Carolina, and although we have a pretty good internet connection, it can be unstable, and it's better for me to switch that off. But I'll come back on during the question and answer period. Let's see if I can figure out how to do this. Okay, so I'm going to talk a bit about our model, and I really like this quotation of Picasso's, and I think we can substitute model for art here. We all know that models are not truth. They are the lies that make us realize truth, at least the truth that's given us to understand. Sounds a bit like Gandalf, but anyway, I like the quotation. So this is a diagram of a model. We have several models like this, but this is the basic plans. And most are single strain. This is but we have a multi-strain model as well. They're SEIR models that have been modified to include features of COVID-19 that might affect transmission. And let me walk you through it briefly just to show you how it differs from the one we've published. So it's an SEIR model. The I compartment has been expanded, and here's the R compartment. There are 3+ doses. The first vaccination doses. The first brings one here, second here. So we don't distinguish infection-induced and vaccination-induced immunity. Immunity can wane. It can wane back to the point where people are susceptible, but at some point, when they still have some immunity, they're at risk of infection. And if they're infected in this model, they pass through a separate track from those that are immunologically naive. And they either develop what we call immunity modified disease or mild disease, or they're asymptomatics. Whereas initially, and the immunologically naive people either are symptomatic or asymptomatic. In both cases, because people are particularly infectious for a few days before and after symptom onset, we distinguish pre and symptomatic stages, which is a crude beginning of a gamma distributed infectiousness. The vast majority of people recover, but some are hospitalized. Some, especially naive people, who died do not die in hospital. About a third, but those who do die, most of them are hospitalized. And that's how this model differs from the one that we've published. And it's due to our so some of the team members are are mathematicians, some are policy people, some are physicians, and our medical people believe that this model, this modification of our model, better suits it for later pandemic stages. The first one we looked at fall of 2020 and spring of 2021. Next slide. Okay, so oops. So that's mostly familiar. One of the ways in which this model differs from others, an important way, is that it's not fitted to any data. Its many parameters were estimated independently, either by us from a nationwide survey of antibodies to nucleocapsid and serum from commercial laboratory clients, from which it also was initialized, or they were sourced from the literature. And by initialized, I mean that the locations populated from the 2020 census in the US were allocated among the several infectious immune states from that serological survey. And initialization occurred in September of 2020, early September. And then several months after initialization and just before vaccination began, we chose one parameter, the efficacy of physical distancing when possible or mask wearing otherwise, at reducing susceptibility if susceptible or infectiousness if infectious. And I would submit that that's an unknown if knowable parameter. And what I did was to adjust that to attain rough concordance between predictions and seroprevalence. And so in other words, this model was calibrated. And the parameter I'm talking about, the expression for the force of infection is down here on the bottom, and it's fairly conventional. There are a number of infectious states, so the numerator here reflects each of those, and the etas are how infectious they are relative to the symptomatic state. A is the marginal contact rates, beta the probability of infection on contact, Cij is the mixing matrix, and the psi functions are shown here, and they're psi s is 1 minus the product of C and B, and C is compliance, and B is that efficacy that I'm talking about. And what we did was to set, and they're subscripted here, but we set them, we made them constant, and we made them constant to each other, and that's the parameter I chose to get the model predictions roughly in the same space as observations. And I'm going to show you this in a bit. This should be very familiar data to you. It's not ours. It's the Prem et al. Synthetic mixing matrix, the marginal contact rates, and the mixing matrix for the US, which is based on the Polymod study of 8 European countries. I believe Italy was one of them. And it's modified for different countries that where contact studies have not been conducted, based on a number of relevant data. There have been contact studies in the U.S., but their results are disparate, and we're comfortable with these. And I should have said first that so mixing and non-pharmaceutical interventions are the only parameters that vary with location in our model. And I'll show you on slide after next that the NPIs also vary with time. Biological parameters vary with age, which is a proxy for the prevalence of comorbid conditions that affect how ill people become if they're infected, and whether they require inpatient care, and that's based on the paper by Clark, and whether they die, which is based on another paper, which I should delete this so I can read my text. So this is what we do within and between locations, and the figure on the left differs a little bit from the one that we published. But basically, it's the ratio of the natural logs of the population densities in the jurisdictions and the United States as a whole. And so you can see that ratio is a bit greater than 1 for densely populated parts of the US, and a bit less than 1 for sparsely populated jurisdictions. And so we multiply those times the mixing matrix. That's within locations. Then between locations, contacts fall off with distance exponentially at age-specific rates, which are shown here. And this figure is we published this a couple times, as well as the algebra by which we calculate those rates. So I'm sure most of you are tired of this this subject, SARS-CoV-2 transmission by now, but I've been with it since the beginning. I was a member of the CDC's International Task Force, and in other countries, smaller countries that were a bit more homogeneous and where public health authorities were obeyed, I was able to model closing and reopening of schools and non-essential businesses and curfews and so on explicitly. But in the US, there's so much spatial heterogeneity in the nature and timing of interventions that was really impossible. And so what we did was devise a function based on the Oxford stringency indices that I'm sure most of you are familiar with. And that's shown over here on the left for these are contact reductions by virtue of government efforts to mitigate the pandemic, and I'm showing you them from one of the spatial models where instead of 51 states, 50 states plus DC, we have our census divisions, of which there are 9. Okay, so another way in which our model is our work is different from others is that well, modelers come in all shapes and sizes. Many are mathematicians or statisticians or engineers, or in some cases physicians. None of those things are scientists. Well, I'm a scientist, and so we try to abide by the rules. If any of you are interested in this sort of thing, I discovered this little book when I was a graduate student. It's only 100 pages, and it's really quite accessible. But so this is why we claim this model is validated. So as I mentioned, several months, well, no. So A is early September 1970. And the lines on here, the blue line is antibodies to nucleocapsid from that commercial laboratory client survey. The orange line here is the model predictions, and you can see I'm not very close at all in Christmas. Vaccination had just begun. The green line, which has not yet been used for the modeling, is from another serological survey. We have 2 of them. Both began mid-2020 and extended through the end of 2021, and we couldn't have done this without them. But this is this one's blood donors. So you see there are no children in that data set. So this is Christmas. We began vaccinating mid-December. And so and this is both antibodies to nucleocapsid with or without spike. So you can see there's been a little bit of an increase in antibodies due to vaccination in that time. But you can see my calibration is not very good. It actually was to a different model in my defense. But the important point is that this is Easter 2021. This is Labor Day, or sorry, Independence Day, which is for us. Sorry, Easter is late March, early April. Independence Day is early July. Our Labor Day is early September, and this is Christmas 2021. So you can see that despite this lousy calibration, the model predictions and this independent serological survey converge, and they remain together for the duration of that survey. So the model fits accurate independent observation, to which it was not fitted. It was not fitted to any data. All other, I mean, this is different from any other model of which I'm aware. Most of them are fitted to surveillance reports of some sort. Hospitalizations are favored because they're relatively accurate. But I'll show you that inferring infections from hospitalizations is really very difficult if indeed it's possible. Well, why does this matter to us? Why don't we fit unless we must? And sometimes we must, but we didn't have to this time. So I like this quotation of John von Neumann's, and you've all heard it. Among his notable quotations is that with 4 parameters, I can draw an elephant. With 5, I can make him wiggle his trunk. our model's mixing matrix alone has 816 squared elements. And the general point is that transmission models have so many parameters that all but the most pathologically formulated ones can be fitted to any data set. But you learn nothing from that process. I mean, and fitting precludes evaluation. And so you're left with a model that fits the data, but you don't know if it's a good model or not. And so I'm a theoretical population biologist, and there are a couple of explanations for what I've just shown you. One is that the fit of this model to those independent observations may be coincidental. The alternative is that maybe we have represented the underlying mechanisms reasonably well. And why does this matter? Well, to somebody like me, mechanistic models are hypotheses. They can't be proven correct. They can only be improved by testing, identifying, and remembering the causes of disparities and testing again. And I began this work, and that was what I told my supervisors that I was going to do. I was going to develop an objective means for doing this. But then what happened was what I've just showed you. There's really aren't any discrepancies after all. But the question, the sort of rhetorical question that I would ask is if models were not evaluated before used to inform public policy, how reliable are the predictions under counterfactual conditions, conditions under which different from those to which they were fitted? And there's a large number of modelers assert, without any theoretical basis whatsoever, that ad hoc assemblages of the predictions of models that have been fitted are reliable. And in contrast, there is a theoretical basis for the belief that deductions from models that have been evaluated and not validated are reliable. And we call it the scientific method. And of course, the more rigorous the scrutiny, the more reliable. But our models are tools for developing and evaluating public policy, not ends in themselves. So after ensuring that we can reduce observations, we design or evaluate interventions by analyzing and simulating them under different conditions. So I want to talk a bit about the analyses that we do. And Alex mentioned that we're a bit unusual in that we can both do analyses and do simulations, and they really are different processes. Analyses tend to be equilibrium, they're static, they involve the functions that one derives and their parameters. Simulations involve whole systems and they're dynamic. And so we try to do both of them. And we want to make sure that they're consistent and that we can learn different things from each of them. And typically we begin with the reproduction numbers and associated quantities. And so each subpopulation has basic and effective reproduction numbers, and we can partition them into the 6 infectious components. And I'm going to show you these on the next slide, but I'm going to combine the pre with the modified and symptomatic states. And what I want you to see, I want to tell you what I want you to see first. Although we assume that people with asymptomatic infections are only half as infectious as those with symptomatic ones, I'll show you that they contribute twice as much to the effective reproduction number. And they also contribute orders of magnitude more than hospitalized people. And remember, hospitalized people are what most folks fit to. And so consequently, in reverse engineering from hospitalization to infections is really difficult. And I mean, our colleagues at CDC use hospitalization to calculate the real-time reproduction number, which is an empirical estimate of the actual effective reproduction number. And that's really, in my opinion, wrong. But here's what I'm talking about. So these are subpopulation now effective reproduction numbers. These are the asymptomatics as a function of age, and again, one of these reduced models. These are the symptomatics. These are the people with modified infections, and these are the hospitalized people. And so the two things to note are that the asymptomatics are young predominantly, and the symptomatics and modified people and hospitalized people are old. The second thing to note is what I told you, full-scale HALO is 1. Full-scale HALO is less than 0.5, so there's a twofold difference here. There's a 2 order of magnitude difference here. So, I mean, hospitalized people tell you very little about the effective reproduction number, which is why I think it's a poor choice for estimating the real-time effective reproduction number via the renewal equation. And certainly we don't need to do it from model such as this. So we find the metapopulation numbers and associated quantities even more useful. And what I'm showing you here are the eigenvectors associated with the nominant eigenvalues, the next generation matrix. And this one can be, the left one can be interpreted as the subpopulation contributions, and the right one can be interpreted as the equilibrium prevalence. And again, these are for reduced models. And if you will, keep the shape of this of the left eigenvector in mind. This is the third shape to keep in mind. So a bit about these serological surveys, and I might have put these earlier on, but I mentioned that they were done during 2020 and continued for a year and a half. We got data every couple of months, I guess, but sampling was continuous, and I'll show that on the next slide. I should say that antibodies are evidence for an adaptive immune response, but they're not immunity. They're only an easily measured proxy for immunity. They're probably a better proxy during the early part of the pandemic than the later part after Omicron came along. But neither of these surveys sampled the U.S. population randomly, and so the reason I drew the diagram on the right, which has since taken on a life of its own, was just to see if the two surveys were seeing the same thing. And we call them internally MASS C and MASS D. MASS C is the commercial laboratory clients, and MASS D is the blood donors. And you can see I had them, both data sets for a particular period of time, which was they were collected to convince our advisory committee on immunization practices to recommend vaccinating children. But here they are. You can see the survey that does include children and the other one that doesn't. But you can see this beautiful hump, which is an off diagonal of the mixing matrix representing contacts between parents and children. The surveys have been described, and there are lots of neat results, but it's the serological these are antibodies to nucleocapsids. So this is infection-induced immunity. And this is the full data set, and I'm just showing you that data were collected continuously. The data I just showed you were from here, but we use stable assays, so the whole data set looks the same as the one I just showed you. And there are other neat things about that we could do with these data that we would not have been able to do. I mean, usually as modelers, we think we're in heaven if we have a cross-sectional serological survey, and especially if we're dealing with childhood diseases where seropositivity increases asymptotically to approach some upper limit. But of course, that's not the case for SARS-CoV-2 immunity. So in the normal way that we calculate forced infection from those data is to assume that age is a proxy for time, but that wouldn't work here because the derivative is negative past adolescence. But we had time, so we didn't need to make that assumption. I mean, that was one of the many ways that we could use these data that otherwise we could not have done. Okay, so what I hope I've convinced you now is that we have a model that's unusual in some respects, and that in particular that it fits accurate independent observation without having been fitted to those data. And I think that indicates that maybe the results of the model warrant your attention. And so what I want to do is show you some more results. So first of all, in the US, the vaccination policy goals were first to protect people at greatest risk of infection, and these were healthcare and other essential workers. That's a non-brainer. And then those at greatest risk of serious disease if infected, and these are largely elderly and otherwise immunocompromised people, and then finally others, younger and healthier people. And mostly people have been interested in morbidity and mortality, the impacts of vaccination on that, but I've been encouraging my colleagues to start thinking about the impact on transmission. And the questions that we have are, could vaccination have had greater impact? And so we try to answer that in two ways. Firstly, by increasing coverage by 5, 10, or 15% among those aged 5 to 19 years. So what I mean is coverage or uptake. I figure out what it is in a given week at a given location, in a given age group and increase it by 5%, calculate the corresponding rate, and then vaccinate at that rate for a week. And the second thing that we've done is to vaccinate at rates proportional to contribution to the metapopulation effective reproduction number. This is really not the calculation we'd like to do. It's a workaround, and I'll show you that in case any all have ideas. But just so this is vaccination during 2020 and 2021 in the US. And on the left, I'm showing you immunizations by dose and age. So initially, the healthcare and other essential workers was pretty flat in the working ages, but then the primary series patterns began to look like this, and increasing with age, first dose leading second dose. About 2/3 of the way into the year, we began boosting. So this is dose 3 or more. And this is running the model with and without vaccination, just to see what the impact of vaccination was on disease. And so you can see that it did have an impact among symptomatic modified hospitalization and deaths. Older people, who are the people in this model who are most likely to experience those outcomes. This is 2022-23. By this point, people who were going to be vaccinated, who were going to receive the primary series, really had received the primary series, and it was all about third or more doses, increasingly among older people. Similarly, reductions in events that policy people care about. So the question though we've had is could we attain policy goals by reducing transmission? And one might expect public health policy vis-a-vis infectious diseases to be designed to prevent infection, but policymakers are largely physicians who focus on disease. Not vaccinating elderly and otherwise immunocompromised people was not an option. It would be a politically incorrect thing to suggest, and so it wasn't an option. But there was a paper that I think is largely correct early on that argued that vaccinating those who might otherwise infect those people would be less effective than vaccinating them. In other words, that the indirect effects would be less effective than direct effects. I don't think that matters at all, because as I said, it wasn't an option not to vaccinate those people. But anyway, and there's an example of that. We didn't stop recommending annual vaccination in the US of elderly people against influenza, absent evidence of impact. We were increasing coverage among those people year after year after year without any discernible reductions in mortality or hospitalization, which had to be pointed out to us by other people. But we did reduce the age at which vaccination was recommended. And allegedly, that was to reduce absenteeism in schools and workplaces. But vaccinating younger people also reduces transmission. If you think about those marginal contact rates, you can see that. But we have other things to look at for COVID-19. We also have this anti-N profile and the age-specific contributions to the effective reproduction number, which I want to remind you of. So the two figures on the left are data. Figure on the right is from the model. But it's not surprising that they correspond, because the model fits the data. But so the marginal contact rates above, the infection-induced immune profile below, and the contributions to the metapopulation effective reproduction number on the right. So this is the motivation for this work. This is these are results from increasing coverage among ages 5 to 19 years by 5, 10, or 15%. And up here on the left, you can see the various kinds of infections are in the first row. On the left are asymptomatic infections, middle is immunity modified, and the right are symptomatic ones.
Just to clarify, these are infections averted, right? So these are
infections averted. Thank you.
Yeah.
And this is by 5, 10, 15% increased coverage. And you can see this curious pattern over here where actually increasing coverage in that age range seems to actually increase asymptomatic infections among middle-aged people. Now, this is a very complex dynamic system, but this is my explanation for maybe wrong. This is my explanation for why that's so. So Most middle-aged adults, especially ones with school-age children or adolescents, have some infection or vaccination-induced immunity. And I showed you that they're going to have infection-induced immunity by virtue of that serologic profile. If so, if infected, most of those people would develop immunity-modified disease. But vaccinating more of those 5 to 19 years reduces their risk of infection. And so those whose immunity is waned when they're infected experience symptomatic rather than immunity modified disease. There's tremendous impact. I mean, the impact is the direct effect is on these age groups. The indirect effects are out here on everybody else. But vaccination directly averts a lot of asymptomatic infections, some symptomatic infections. These other things. My medical colleagues don't want to have to try to explain this, so they have me combine that together and that's shown down here on the left. So these are symptomatic infections, hospitalizations, and deaths. So you can see that increasing coverage among school-age children and adolescents would have impact on the kinds of things that policy people care about. Well, so the other question that we've asked is, what if the dose administered at each location had been allocated in proportion to the age-specific contributions to the effective reproduction number? And this is not what we'd like to do, but it's a workaround. And let me tell you what we've been trying to struggling with. So first of all, let's write the effective reproduction, the metapopulation effective reproduction number is a function of the we'll work with 3 groups. It's a function of Chi's, the vaccination rates. And let's also have a certain number of doses, and that's available. Let's call that C, and that's got to equal the sum of the product of the vaccination rates and the numbers eligible, and we'll call that function F. And we can define the gradient of the effective reproduction number this way. And then for the optimal solution, we need to solve this equation. The gradient of the effective reproduction number equals lambda times the gradient of F, where lambda is Lagrange multiplier. Basically, what we're looking for in 3 space is the intersection of this plane and a surface. And so the gradient of F is simply the ends. And so we have this equation, which is equivalent to this, or we can rewrite this and eliminate lambda. And so we have these 2 equations and the constraint, which is 3 equations with 3 unknowns that we ought to be able to solve for. But Mathematica tells us that there aren't any solutions with non-negative Chi's. The problem is it's not considering the possibility that we think the problem is that it's not considering the possibility that 1 or more is 0. So this is something we're struggling with right now. We haven't, it's what we want to do, but not what we're doing instead is, I think, similar, but not exactly the same thing. All right, so anyway, this is, I don't know if you remember that pattern. Maybe I should remind you what the pattern, so this is the actual vaccination pattern in 2021. And if I do that optimal vaccination, this is sort of what it looks like, and it should be a familiar shape. It also causes reductions in outcomes of interest. It also reduces the effective reproduction number, and what I'm plotting on the lower right is just the it's the actual minus optimal divided by actual. So the actual reduction can actually be approximate almost half. In some cases. That's 2021. This is 2022, 2023. Incidentally, this finished, these runs finished early this morning. We had a, so I haven't looked at them very much. We had a power outage and I lost everything on that I was working on, but this is the next year. It's a similar sort of thing. Most of the doses are being allocated to 3rd doses. Also reductions in events of interest. Also reductions in effective reproduction number. Sometimes as large as a quarter in this case. But it looks like, all right. So this is another way of looking at this. So what I'm plotting over here is the difference between the optimal and actual immunizations due to vaccination. You can see the optimal vaccination program favors young people, and the actual vaccination program favors older ones. Same is true both years. What I'm showing you here is the difference between the events averted by the 2 strategies. And what this shows is that with some exceptions, the actual strategy averted more events than the optimal one did, which suggests that that paper that I mentioned didn't really matter is probably correct. At least I'm not, I make my colleagues uncomfortable sometimes because I'm not willing to give our government a pass, but it looks like given the goal, that is to reduce disease among immunocompromised and elderly people, the actual strategy did the job. But this is the kind of thing I'm thinking about. I think this is my next to last slide. I think we want to encourage more vaccination of young people. I think we want to do both. We want to really, but parents were understandably loath to vaccinate school-age kids and adolescents, and because even though adverse events were rare, infections were largely asymptomatic. So even though vaccine was free in the U.S., I mean, I can imagine being a parent. I mean, my kids are old now, but being a parent of young children asking, what's in it for me? Why should I do this? Why should I run this risk? Well, another observation is that health equity is a priority for us. And in closing schools, we now know closing schools was exceedingly costly, especially for students with impoverished home environments. And judging from the similarity, the marginal contact rates and infection-induced immune profile, I hope you notice that. That is exquisite. I mean, you can see in both of them, you can see the context between parents and children. It apparently had little impact. Closing schools apparently had no impact on. There's no evidence that it had that contacts among school-age children and adolescents were reduced at all. Third point, there's precedent for what I want to suggest, which is that in the U.S., childhood diseases are controlled by vaccine-preventable childhood diseases are controlled by school entry requirements. You either, if you're not vaccinated, you don't go to school unless you have an exemption, a medical exemption, or some religious or personal belief exemption. So my question is, why not consider teachers, administrators, school administrators, and others as essential workers and prioritize the vaccination of school-age children and adolescents and reopen schools for vaccinated students as soon as possible? I mean, we'd have to do a couple of things. First, we'd need to expedite vaccine safety evaluations among young people and convince parents to vaccinate their children and adolescents. But I think reopening schools as soon as possible for vaccinated students might motivate parents to vaccinate their children. And I believe it would reduce inequity, transmission, and maybe mortality, morbidity as well. That I think is my last slide. I have to read this. I have an obligatory disclaimer that the findings and conclusions of this report are those of the authors, largely me. They don't necessarily represent, certainly in some cases, the official positions of the CDC or National Science Foundation, where Salon works these days, or Queen's University, where Troy is. Let me stop sharing and turn my screen back on and ask for questions.